Okay, good afternoon, and thank you, Vizomac, for the kind invitation and giving me a chance to speak to this August gathering. And my apologies, denying the coffee break was definitely not my idea. That is Anirudh's doing completely. Right. Uh, with that disclaimer, I'll try and be very brief. And we need not prove that paclitaxel or sirolimus is spreading the toxicity around here. We'll reduce the toxicity as far as possible. uh, okay. Drug elution in venous tree. The first time I was assigned this topic, I thought it was such an elusive thing to talk about. What am I going to speak? Okay. So always start from the basics whenever you are confused. It starts all with the neo-intimal hyperplasia. This is taken to be our bane of existence as far as all endovascular or surgical interventions are concerned. Right? What we are trying to forget is it is a positive adaptive response of the body to any vascular injury. The moment we take in our first breath, the fetal circulation itself is actually, the fetal circulation occludes by neo-intimal hyperplasia. And this is also the pathophysiologic response that we wish to reduce when we are introducing a therapeutic vascular injury. There are this little bit of science behind it is, as usual, the hypoxia and the endothelial dysfunction. Frankly, this becomes more accentuated in a venous tree, leading to much more severe venous neo-intimal hyperplasia, which we have seen in chronic venous disorders. We'll end up with synechiae, far more number of synechiaes and fibrosis than compared to a arterial tree. Conventional techniques, how we reduce the neo-intimal hyperplasia, as Rutherford describes it, they say that your tissue handling is always the reason behind a successful bypass or an occlusion of your vessel. So the severity is how much damage you did during dissection, how much injury did you cause to the tunica media, that's a layer of the artery, and how much of vasa vasorum did you destroy while handling the adventitia of the arterial wall. The veins have a very higher amount of vasa vasorum compared to arteries. And whenever we do a venous vein graft harvest, that is where we damage is the most. And that is why at an anastomosis point, we get the maximum amount of neo-intimal hyperplasia. With that basic knowledge, we can move forward. And so it is very easy to say that how do you prevent it? You reduce the vessel handling, meticulous dissection, and especially during endovascular intervention, no eyeballing of the lesion. If you think that it is going to be a 7-size balloon, go 6. If you think it is 6, go down 5, 5, 4, and in that manner, you will never be wrong if you are trying to eyeball, and that is how you are going to reduce this effect of NIH. The last factor is prevention of low outflow. Always remember that is the inflow, outflow, and the conduit. So if you take care of the inflow and the conduit, and then finally the nail in the coffin is your outflow vessel has to be ensured that it is there. So do not blame yourself that, I did everything right, and why is the pedal vessel not picking up? Now coming to use of DCB. Most data of in venous tree has been from the dialysis axis, and it has got a variable result. Katsanos has been the hero of this meeting especially, and he has been mentioned in many talks. And in fact, I have put his review article actually to understand how we can improve our dialysis axis results rather than going into other meta-analysis. Venous bypass grafts, this has been given. They tried a smaller number of series, but I think very soon they realized there was no significant difference was seen between a plain POBA or you stent the lesion or you do a DCB, drug-coated balloon. Chronic venous thrombosis, that is something the latest result, anecdotal incidences have been reported in pulmonary veins. That is where, but you require a high pressure balloon there, bigger size, 14, 16. I think beyond 14, 12, it is not available. and you require bigger size of balloon, and the dose delivery of paclitaxel in such areas is going to be very huge amount. So that is why it is being used cautiously, little more off-label use. Hepatic veins, again, there is an anecdotal incident. I almost considered an IVC thrombosis when we had an extremely sick patient, but thankfully we got away with a plain POVA and alteplase to some extent. Hepatic veins, where they have used is where they wanted to take up the patient for a liver transplant at a later date and did not wish to stent the hepatic veins. Again, as I said, mostly off-label use. At our Sir Gangaram Hospital and AHRR also, most 95% use of drug-coated balloon has been in arterial tree. This is a disclaimer that we barely use them even in arteriovenous grafts. Use of DCB is extremely selective cases. If there is a spot lesion which we do not wish to stent and there is a lesion collapse after a POVA, then only we do a DCB. Otherwise, we don't do it. What the real life data says. As I said, Katsanos, again, there are at least 2-3 articles and there are others also. There is a small series on drug-coated balloons. There is a small series on drug-eluting stents, and the bigger drug-coated balloons for dysfunctional vascular access. It is by Katsanos again, this review article, which has taken off from last, I think, 2012 onwards, as many studies, some 39 studies he has considered, and his pooled data has been used. To go back, to understand this, what he has described as actually a vascular access circuit. The point of stenosis, point of stenosis are usually the vascular access cannulations. In a AV axis, it is the vein which actually is the most stenosed part rather than the anastomosis. And in the AV grafts, it is the venous the graft vein anastomosis site is the site of most of the stenosis, or even the restenosis for that matter. So why do you see restenosis and restenosis? Again, because of the angulation of the anastomosis that we sit in, and then transition from a low to high flow system. And surgical manipulation, which leads to the damage of the microenvironment. As I said, vasa vasorum needs to be protected more in the veins rather than in the artery. Of course, systemic disease condition, that inherent systemic disease that they come to you with, uremia, oxidative stress, and hypoxia, is a given in dialysis access failure. Plain POBA, it can lead to, very easily, it can lead to a very successful outcome. It can, again, generate a same cascade of events leading to NIH. The whole idea, again, I don't need to amplify it any further. This is the various balloons that have been used in this study. These are all purely paclitaxel-based data, and Lutonix, Impact, Apeto, Pasio, all kinds of them, and with how much of dose was delivered during this dialysis, during this balloon angioplasty, that has all been recorded. They took 39 studies. They included both AV graft, AV accesses, AV grafts, pure AV arteriovenous fistulas, central vein stenosis, very few studies. And the results, first RCT, again, they took 40 patients. The comparison was PCB is superior. Second one, again, PCB was superior. The number of patients increased from 200 odd. Then they started a subgroup analysis. They found AV graft again had a much better result than the veins showed a better result than the AV grafts. Then finally one study came from, I think, Slovenia, which said there was no statistical difference between plain POBA or you do a PCB. Jockman and et al. He was the first RCT which showed the worst results at the end of 12 months. Netherlands study which came out, I think this is 2015 or 16, it came out and said no, the worst results. And surprisingly, basically there is no cardiac toxicity has been, or an increase in the mortality rates by use of DCBs in dialysis axis, that angle was taken care of. It did not add on to the mortality factor. Okay, the roadmap to successful PCV treatment, the site where you must use this drug-coated balloons was that the steps that you must use. And in this chart, they clearly show that the site where you must use, if it is the vein which is harmed, the vein, entire vein, the stenosis site has to be addressed. AV graft, only the anastomosis site, arterial anastomosis, you need not do a DCB, you need to do a vein site, and maybe the outflow vein also needs to be taken care of. Central veins, not significant number of roadmap available for that. But first step is vessel preparation and dilatation. This decides whether your DCB is going to work well or not. This is one, just for an example, this is outflow vaselic venous stenosis. As you see, the site of the lesion is this much, and the POBA balloon is on your left, which covers between these arrows, and DCB is a little longer than the POBA, the balloon used for the POBA. So that ensures the success rate, and the lesion collapse will not happen after you use a DCB of a proper size. It has to be centimeter more than the normal balloon. Again, a couple of cases, what we did here, we did a complete angioplasty of the vein axis here, which had completely collapsed. It was an occlusion, and we did a DCB, and this is the posterior result. I think 3 months down the line, it is still working. This is again an AV graft at the venous anastomosis site. We did a DCB. Result is acceptable enough for the graft to work. We don't know how long it is going to really continue. So learning points. The only learning point out of this is data is still inconclusive. If you feel your lesion is going to collapse, then you have to change your strategy and then take in a DCB. There is really superiority of DCB has not been proved clearly. If it is a vein which is collapsing, the results are much better. And what is the next in line is to analyze the various subgroups, the data is coming up, the lesion characteristics again, to see which group will benefit most from this technology. Thank you.